Hello, everybody. Welcome to the Healthtech Pigeon podcast, bringing you the top news stories and analysis every single week. I'm James, and with me I have Dr. Keith Grimes, OG health tech guy, is all about the technology as we've known for a very long time, but he has just, as part of a group, published the largest study of NHS digital safety compliance. And the findings are relatively concerning. If I can just summarize, 14,747 digital systems in use, 70% with no documented safety assurance. And in a typical NHS trust, only 1 in 4 tools meets minimum legal requirements. Keith Grimes, welcome. How you doing?
Good morning, everyone. What a way to start, eh?
Somber mood to begin, isn't it?
Well, yes, but equally within this, there's a lot of reason for hope because we know where to go now as well, and we know where we stand and how to proceed. So yeah, those numbers as you talk about them, they do sound worrying, and we shared this on. It was published on Halloween in the JML.
Was that intentional?
No, nothing to do with us. But I'm in Boston just now, and I was flying out, so I had the Wi-Fi on, and then I got the news, and I was like, "Oh, here's the timing." Yeah, I mean, so the numbers do sound worrying, and they are concerning. I suppose some important context in that, with those numbers, 14,747. That's not like all different bits of software. There's a lot, that counts on the sort of deployments. You have one technology used in 100 places. That be 100 of those. The relevance of that, of course, is that whilst demonstrating that a product is safe, the manufacturers will do this, and then maybe do that, the once for this technology. When it comes to, I suppose, any deployments, but particularly with clinical safety under the DCB standard, there's a bit that needs to be done by the deploying organization. Why is that? Well, you say this product is safe if you use it that way, and then you put it somewhere and they'll use it that way. That's what they're committing to. But it'll also have some little local variations. It's that last mile, and that's where all the little hiccups can potentially happen. So this standard accounts for that by having people deploying the technology look at the safety documentation and then think, okay, but if we're using it here, does all the safety arguments still stand? Is there anything new that we need to consider? And then they take a structured approach to that. And in that way, you're minimizing the risks that something might go wrong. You're committing to keeping an eye on things and improving it. And in that way, you get the best kind of outcomes. So it's a standard that I like, and it's been around for a while, but knowledge of it still seems to be rather poor. So we're hoping to change that.
I got loads of questions on this because it's, I mean, I think this is just an important time, isn't it? Now that this has been done, because the reaction to this, what we end up doing, what various organizations end up doing is going to be incredibly important. But I want to start at the beginning. So what prompted you to think about doing this study? And then how did you, very practically, how did you actually do it?
Well, I mean, the first thing to call out is that I've worked with some of the team at UCL, particularly Dr. Yusuf Oscroci, Elliot Roy Hiley, and the Emperor Sam Shah, with all of this as well. But working together, so I know them, and we do work together. And as I work at Curistica, my business, where we work on compliance work for manufacturers and also people deploying technology, particularly with AI. And as we were doing this, we were aware that on the manufacturer side, it was variable knowledge and understanding of this DCB standard. And we were asking, why is it not being done all the time, but people don't know about it? And what turned out is the feedback was from manufacturers is that the people they were selling to weren't always immediately asking for it. They were asking for some things, but not other things. And of course, when you're balancing a lot of demands, you're going to go with the ones where the greatest pressure is. So it got me in use of thinking and saying, well, Why is it that they're not being asked for this? It seems clear that they should be, but why not? And
Mm.
then on the ground, we saw that the people deploying it were also sometimes less aware of it. If you're a clinical safety officer listening, you'll know that sometimes it feels like quite a lonely path, and you're often having to sort of fight your corner. And so we started to think, well, how do we find this out? You can observe place by place, but of course, within the Freedom of Information Act is the opportunity to be able to go to these organizations and ask
Mm.
them if the information isn't readily available, which it wasn't, for them to provide it. And so it was with that idea and again, the knowledge and the drive of people like Yusuf and Elliot and that team, um, the process started. And it started by, well, what questions do we want to ask? And they are, on the face of it, fairly straightforward questions, as the standard requires. What digital health technologies are you using in the provision of patient services? We address this to trusts, ICBs, ambulance trusts, and things like that across England, where the legal requirement is in place. So, what's the list of the technologies? How many technologies do you have? And
Mm.
then, of those technologies, do you have the 0129, which is the manufacturer's side? Do you have the 0160, which is their side? And then, how many clinical safety officers do you have working with you and your employee? So you get an idea of the sort of resource they have against that. And then that went out. The paper has the full details within it as to the timings of all of this. But what's it? There was 239 organisations approached, of which 85.4% responded. They didn't all respond within the timely period, but
Yeah,
that
of course not.
responded. And then with that, within that, there was a 81.3% of that whole number then provided either full or partial information. So I suppose there's a lot of variation in how they responded. Again, maybe illustrating an imperfect understanding of what is actually required, because when you ask the respondent for this, if they don't know about the standard, then they may rightly question why you're asking and so on. But the second thing is that this information wasn't readily available, as in it's difficult to get this information, is also a bit of a concern, because you're meant to have this information reasonably, available, because you're meant to be keeping it up to date. So just even in that first little bit, there's some signs for worry that this is proving tricky. And with that information coming back in, that was then over to the engine room, where the processing of this and looking at all that information, and there's wide variation in the responses. Some places totally compliant, some totally non-compliant, and then many people sitting around about the 25% mark.
It's really interesting, Keith, because obviously you and I clinically trained, and patient
Mm,
safety is always like the number one for us. Like no matter what we end up getting involved in,
mm,
like you can never shake it. The sort of integrity that comes along with, at the end of the day, this thing has to be safe. And when I read it, like that's the overwhelming sense that I had with this when I read that is, hold on a minute. And I know you said something similar in your LinkedIn post. Actually,
mm,
was hold on a minute. I'm over here doing podcasts with tech entrepreneurs, and we've got this Healthtech Pigeon newsletter and the podcast that goes out, and we've got all these people that we're we're saying this should be adopted, that should be adopted, this should be across healthcare. And not every tech is for the NHS, but some are. This would be great in the NHS. This should be scaling in the NHS. And I'm sort of part of this movement where you know and critical appraisal goes on our side of who we bring
mhm,
in and all that sort of stuff as well. But I'm then, once I've decided the horses I'm backing, and the people that I want to see win and the companies that I want to see win, like I am then pushing them. But the feeling reading your paper was that you're pushing them on a system that's not ready to receive them. You're
mhm,
pushing
yeah,
these very complex AI technologies into a system that isn't actually potentially structured, fit, like ready to cope with it. And ultimately, what I want is for the deployment of technology to happen to make conditions better for
mhm,
workforce and for patients. And timing is a big consideration there, because if you do that too early onto an infrastructure that can't accept it, it risks a lot of things. And that means that this is all in vain. And this hasn't actually gone and done the thing that I want it to, because we've been too, I don't know, like trigger happy trying to get things in. Do you see what I'm trying to say? That's the sort of feeling that I had of like, hold on a minute. Like, do I need to spend a lot more time talking about how to get infrastructure in place by organizations to actually start to marry these two things together, you know?
Why are you and I in this, James? Um, it's because no, but I'm gonna be positive about this. My goodness, is it a complicated problem? There are so many factors to it,
Yeah.
but and I've used this phrase before, it is a delicious problem to try and solve. Like if you want to try it, like the combination of all these things, you may come up with the digital cure for cancer. Like,
Mm,
congratulations. But if you have come up with such a thing and you want to get it in front of people, and of course, why wouldn't you?
of
You just
course.
solved one tiny little part of the problem, and you just illustrated the other part as well.
Mm,
It's like, people have to be ready to receive it, use it safely, all of those things. So, I'm sorry to all the founders and everyone out there. It's not as easy as you maybe hoped, despite how brilliant it is. But the good news is that you're a smart and driven folk, and you just have to sort of wrap it in, and then along the way you will necessarily have to make some compromises and decisions as to where you focus your efforts. And actually, the readiness to receive this and do clinical safety is part of that, of course. Um, all that I would ask is that we consider it. We don't file it under too difficult or someone else's problem. It has to be in there, and then on the whole, you then work together to try and get through. And so, yeah, you're absolutely right. Um, these are increasingly complex technologies that require, it's like having a car that's, very powerful, but has lots of features that you need to
mm,
understand. You need to understand how to do this to operate it safely. And we're starting to put those things in place. And we're doing so with a workforce that is totally frazzled and resource constrained too. So, yeah, there's a lot to consider in here. But what we're talking about here with technology is at its heart no different to what we talk about with just general clinical governance. Is the doctor or nurse that's treating me qualified and safe and stays that way to do so? Is the work that they're doing to the quality that we expect? If we identify things going wrong, can we address that and bring it round? I think we all accept that, and we do a reasonably good job of that. Yeah, and it's the same with drugs. We understand the basics of how these drugs work. We get licensed
mm.
prescribers. They maintain their skills. They prescribe within their competencies. They watch what's going on and monitor their performance. Again, I think not many people are going to push back against that. Technology's no different. No different. It's like it does. I mean, I've been guilty of this too, but people feel that it's in some way different. There are differences, of course, but the basics are, does this thing do what it says it's going to do? And is it safe? Does it stay safe? Can I use it? If it goes wrong, do I know what needs to happen? That should sound familiar, because we do that already with everything else. I think one of the things that makes it harder is that, and I've talked about this before, we are not teaching people nearly enough the basics of this at undergraduate and postgraduate level. You'll get all your
Yes.
clinical practice, you'll get your, clinical pharmacology or pharmacology, but there's hee-haw about, you know, AI, technology, data science, and so on. So, it's unsurprising that people maybe see this as difficult to wrap their heads around. It's for someone else to do.
Mm,
The news for everyone here is no, we've all got responsibility if we're working in this space, regardless of where you are. But there are ways into
mm.
it. So yeah, that's the overarching part. Is that I'm sorry, these things aren't fire and forget. You can't just buy it, put it on the shelf, and say, "Job done. I'm just going to use it." Nice as that might be, you're an active participant in this.
Part of what you talked about in your summary was clinical safety officers and
Mm.
I guess the requirement on them to do multiple different things. This isn't something that you can go into quickly. This isn't something that it's not a role for. I was going to say for the faint-hearted, but I mean on some level,
There's no
professionalized might be a good word for it. You know that. that you talk me through your thinking on the clinical safety officer role and what your recommendations were there.
Sure. So, clinical safety officer is a role that is described within the DCB standard, and this is registered medical professional, doctor, nurse, pharmacist, someone who's registered with a professional body, not necessarily practicing at the time, but registered,
Sure.
who has experience in that clinical space and training in clinical risk management, uh, that is there to look at the impact of these technologies on patient safety at its heart. Um, and the way that you become a clinical safety officer is, there's training. How it's currently offered is, so through the NHS you can get the training. There's some online training, and then there's a one-day practitioner course, which takes you through the core activities about clinical risk assessment and evaluation and analysis, and then creating the
One
artifacts.
day, you said.
There's a one day in person. There's pre-reading, but it is short. Yes,
Right.
I think I
Yeah,
was
yeah.
looking through all the comments, and Hugh Harvey brought this up as well, and he's entirely right. This is an important role, and then you can, over a weekend you can become that. Now, like, you've still got all these are people who've generally got a little bit more seniority, further in their career, they've got their clinical background and so on, but it is still pretty lightweight. And then I always think that you come out of it, it's a bit like a provisional driving license. A lot of car analogies here,
Mm.
but you
Yeah, okay.
now you're okay to go out and in a careful way sort of go on the road, and then that's thereafter you start doing the work, hopefully in the shadow of some other people who've done this before. Well, that's not always necessary, um, and go through the process and then start to do the important bit, which is using your knowledge across all these areas to make judgments about what risks you're dealing with and recommendations to get the risks down to a level that is acceptable for the use that where you're going to put this. Um, is 16 hours worth of training enough? No. But people have to get on somewhere.
Yeah,
Um,
yeah.
and and the missing part is that kind of ongoing support training and upskilling and so on. And there's actually some really good work that is arising, although it's coming from the CSO community more specifically. There's Kay Reynolds, who's a CSO, and she does something called Coffee and Chat, and it's a monthly meeting, and it's great because it brings together CSOs who, once you wear this hat, it's quite a lonely thing. You're now responsible for this, and there's no one else in the organization that really speaks your language or carries that load. So she's brought
Mm.
that together where CSOs will speak to each other and compare notes and practice and share their thinking. Nice to have that formalized, I would say. Um, Also, sort of
Mm.
ongoing training, your recommendations of what competencies are required after you've had that first part. And then I would ask that there's maybe a central registry as well. Um, we do need more CSOs, and you have to get on somewhere. But we do need to start making it easy to know who has, the core competencies, and when it comes to the deployment, understands the specifics of the technology and the context of where it's going as well, because like I said earlier on, that's where a lot of the risk lies. um, you know
Mm.
in a general practices are very, very specific, and they vary a lot in between them, or in a hospital, or if it's a mental health trust or an ambulance trust. You need to know how things are going to work there.
It's a really interesting role actually as well, because as you say, the requirement for knowledge across a few different areas, but then actually the amount of impact that you're likely to have as doing that,
Mm,
the ability to do
mm,
it, right, if does the training need to be longer? Yes, but still, we're not talking like a 3 to 5 year degree here. We're talking about, something you can add on to your clinical training and do over a certain amount of time that then gives you the opportunity to get involved in some serious heavy hitting conversations about the future of technology in that organization. Like that's actually that strikes me as like a really desirable thing to be. I mean, you are then
mm.
perhaps loaded with some responsibility as well, which is the other side of the coin. But for clinicians that already by definition of their job and role and vocation have integrity and are going to do their best, and with documentation and frameworks and all that, the way that you do your job fitting into a system, you know actually, like if you can
It's a pretty
minimize
good
that
fit.
Yeah, exactly, exactly. It really feels that way,
Mhm.
which is
And
really nice. Yeah, I can definitely see it being very desirable.
yeah, and what's also nice about doing it, and the fact of doing it as well, and the bit that I enjoy is like I like the tech, right? Okay, we'll take that as standard.
Yeah.
But the bit that's really rewarding is that when you're in a hazard workshop, this is the point at which you're looking at a sort of systematic breakdown of what this thing does and what can go wrong at each point, and you're sort of noodling away like a detective with everyone else trying to
Mm,
bring it all in. And then you're left with this sort of situation, well, where this bit of the technology goes wrong, it means that the whole product will behave this way, and that might lead to this happening, which might harm a patient. You've got that kind of chain from the cause all the way through to what hazard that presents and what harm hands at the end. And you're sort of identifying the controls, the things that will either prevent it
mm,
happening or recover from it happening. So you've got all that in place. But the great thing is, if for clinicians who have real world experience, is you can immediately start to ground it in the actual reality of it, because it can be very tempting when you see this. If this goes wrong,
yeah.
then this will happen. And, will this go wrong? Or it may go wrong. And what will happen? Someone will die, right? And it's very easy to sort of jump to that end. But what you want to be able to do is go, well, but like, what's the sort of realistic top end of this? And you can think back and say, if you're a nurse having worked in theaters, for example, and you're looking at that, you'll say, well, look, I've done this for 10 years. This weird scenario, like, I've never seen that happening. People don't do that. And so even though theoretically it could do that, actually, in this situation, it's very unlikely to. And that's where the value comes in, because it's about being
Mm.
pragmatic. And that comes from being there in the trenches.
Back to the paper. Can you tell me about the primary care blind spot and what you mean by that?
Yeah. So what I mean by that, so when we looked at this, we looked at trusts and ICBs, and because we want to be able to get hold of this information, and Freedom of Information Act gives us the means to do so. Um, and there's 239 of them that we approach. But if we looked at primary care, I think in the UK, oh, and it's important to say at this point that this standard is legally applied within England. And of course, the UK is more than just England, it's Scotland, Wales, and Northern Ireland. And so, whilst it doesn't have that legal force there, it is quite commonly adopted. So if you look across the UK, there's about 7,800 practices. Do you then submit the same question to like every single practice to do this? That may not even be possible. It's certainly deeply impractical to do so. Um, so we don't have that number just yet, but we're looking now, Yusuf, Elliot, Simon, I, and maybe some others, as to how we can start to get that information, because it is important. But the second, so we don't know. But then the second bit is, well, how has this been handled in primary care up until now? Now, a general practice, like a standard general practice, um, how many technologies does it deploy in the service of its patients? Now, it's difficult to say exactly what that is, but it's in the order of 10 to 15 different technologies, everything from their EHR to an ambient scribe and all these things, all the
Mm,
way down
yeah.
to the software they use to run for spirometry and stuff could conceivably be considered. So you got all those numbers. The next question is, well, who procured that? Who got it for them? And a lot of these things are nationally procured. Yeah. So, but the ICBs, if you're looking at England, were the ones that would be responsible for this. And of course, many of them have the teams and discharge this work in a sort of central level, which then cascades it out of the way. But with all the changes that are happening to the ICBs, there's been a sort of left shift of this. What's happening is the responsibility is now being pushed back onto practices. And the trigger for this was with scribes. So in June earlier on this year, a letter came out from the NHS England's CCIO saying, with regards to scribes, you must have a clinical safety officer, you must get your data protection in order, all in black and white, and came out.
Mm,
Many ICBs were then saying, well, of course, but this is a decision for the practices, so you are now responsible for this. Of course, they don't have CSOs. They haven't had CSOs. They might have,
ah,
one or two of them might have it. They're already having to deal with everything else under the sun. And they really want to use scribes and they want to use it right. But what do they do? So part of the work that we do at Curistica is doing exactly that. And there's my declaration. There's an interest there, of course, helping
Yeah,
practices
of
and
course.
PCNs and ICBs. But there's other people doing this too. Um, so some people are going, oh, I'm just going to train a CSO. Right. And we've just heard about like training a CSO. It's not just that weekend course, there's more to it. But critically, this is unfunded work. It's just been shifted back the way. There's no funding gone with it, and
Mm,
practices aren't replete with cash or time on this one too. So it just becomes yet another headache. And then they've got to cover it across everything else. That is this kind of blind spot, and like things have happened many times in the past for poor primary care physicians and clinicians, is it's just being shifted back the way, and some of them are at a loss. They're all working their way through it, and I think given that this is happening, and given that it's not just scribes, it's all of their technologies they have to look at this. How on earth do you
mm,
square that off? That's why we're focusing on helping that area and helping manufacturers who are selling at that area to help people do it. But that's the bit that worries me, particularly when the government wants, quite rightly, hospital to community, sickness
yeah.
to prevention, analog to digital, the three big things there.
Mm,
Hospital to community, analog to digital, primary care, now responsible for all this sort of stuff, no money
yeah,
flow
that's
back.
literally 3 for
How are
3.
we going to
Yeah.
achieve that if we don't sort this? Yeah.
Yeah, agreed. And it's a confidence thing, isn't it? Because you can argue, people can always make the argument that regulation and governance will always, stifle innovation. But actually,
Hmm.
I think one of the big problems is a lack of confidence in bringing something in because a group of smart people will just look around and go like, "Can we bring this in? Like, is this the thing? Like, should we? Can we? Like?" And actually, it's not the fact that 14,000 unsafe technologies are killing people currently. That's not what we're saying here at all. Because again, like we've talked about, these are people with integrity that put patient care first, and actually they're going to do their homework. But I mean, I think I don't know about you, but I think something like this that gives people then the confidence to then deploy, are quite likely to deploy more things. And actually, it's maximizing that upside that I think is the real kind of value proposition here for this, which is that at the end of the day, we want people to feel comfortable and confident that they can deploy technologies, knowing that yeah, if things were to go wrong, it's been modeled, it's within a framework and all that side of things, without the
Done everything you
uncertainty
can
of
to
hold on a
stop it.
minute, am I on the chopping block? Yeah, exactly, and then done everything I can to mitigate for that stuff.
And also it's good news, like if we get it right, it's good news all round.
Yeah.
And we'll start with the most obvious thing. It's good news for patients who might actually
Yeah.
reasonably expect that this was done anyway. Um, so so that's part one, and the families around them. And then the people delivering their care might reasonably expect that
Mm,
this work has been done, and it cascades all the way back up.
indeed.
But if everyone's operating this way, and if you're a prescriber, you prescribe dangerous things all the time, but you've learned, the limits of what to do and how to watch out for. Um, if you're a manufacturer of this technology, you really want people to tell you when things aren't working,
Yeah.
because
Also very
you
true.
want
Yeah.
to you want to make your product better, like deal with all the sort of thing. And if once the communication is more open and information flows back, um, as a manufacturer, like, well, I think this is going to work in the real world. I've done all the work that I want, and
Yeah.
and then you hear nothing. Then you're like, well, what do I do
Mm,
next? Yet, if you have the information provided back the way, saying, actually, we've provided this out here. You thought it was going to work this way. Lots of things are going great. This one thing does seem to be going pear shaped more often. I,
mm,
I want to know that if I'm building something, I'll say, all right, okay, well, this is the bit that I'm going to focus on. And then the update gets pushed out, you do the necessary work, and everything starts to build and get better and better and better with customers, if you're a manufacturer, that increasingly trust your openness and are open to new things. They're ready for
mm.
more. And when they're ready for more, they're ready for the great things that you're building, which can help the patients and their families. So yeah, this is a good news story.
Love it. No, love it. What's the immediate next step on this, and what's the hope over what timeline?
Well, the immediate next step is there's a few things in there. There is a consultation on DCB underway. It started earlier on this year, and I think they're into not exactly sure where they are with it right now, but it's still underway. So it's great that if this information was then considered, as they consider what changes, if any, they make to DCB. It's a good standard, but there are ways in which it could be improved and streamlined. So I'd love them to take a look at that. That's part one. Part two, it's helping those people in leadership in organizations. And so we talked about ICBs and trusts here,
Yeah.
understand what they need to commit to in terms of resourcing and responsibilities to allow them to meet either their own aspirations or the instruction that they're receiving from on high in the government. This big press to digitalize everything. We've seen the 10-year plan, we've seen the medium-term plan. All of those things, it's not just I'll just buy a bunch of stuff and deploy it. It comes with some other things to consider, but then that unlocks everything else. I think making sure that we identify and support clinical safety officers and start to think really deeply about the importance of the competence and experience and quality of those people. It becomes very difficult to get like a highly expert CSO in every single location. I think there's going to be a balance where that you may have those more experienced over a wider area supporting groups thereafter. I think that's a very nice way of doing it, to get that in place. And then that central registry. And then there's one other thing which has always been a bit of a headache is it would be great if all these clinical safety cases, the packages of information about the safety, there was a repository for it.
Yeah.
And
Yeah.
it was there in a way that we could all learn from it and share it. And manufacturers will rightly sometimes have concerns about clinically sensitive information or commercially sensitive information within this. There are ways to balance that out, but we do need to start sharing this and learning. And then one final bit is there's no enforcement body for all this. The question is like, why did it get 70%? Well, no one was checking. So we need to sort that out. Now, could that be the CQC? And the CQC have their own challenges right now, but the CQC do look in the clinical service providers to provide evidence that the care that they're providing is safe and effective and caring.
Yeah. So they're there
And
anyway.
technology
Yeah.
is part of that. And
Yeah.
they have, to their credit, already indicated what they might do. We at Curistica and many other people that here are speaking with them. We've got our own thoughts on how we work with our clients on making them CQC ready, but we're still not exactly sure what the CQC want. So there's that. But the industry side is, I'm open to suggestions on that. It's not entirely clear how you would do that part. And equally, we don't want to just have a whole bunch of bureaucracy that just slows everything down and makes everyone upset. It has to just mean that effective technology that is safe helps patients and the people caring for them as well. And to that end, there's some good noises coming from government and announcements about how regulators are coming together, AI airlocks and the like. So again, I think there's really
AI
positive signs.
airlocks. What a
Oh, you must have
buzzword.
heard about
What
the
a
AI
buzz
airlock.
phrase that is.
Yeah. Oh, I thought this was old news, but the AI airlock was these situations where you can get new technologies essentially piloted in a very sort of close scrutiny way with the input of the regulators. So it allows you to use technologies that might otherwise look like they couldn't be used because of regulation or legal issues and things like that.
Nice.
So the second round has started up. I think Harris Schrabe, Newton's Tree was in one of the first ones, one of the people that I knew.
Oh, yeah.
And I know that Dom and Tortoise are in the second one. I'm there's other ones that I apologize to the people listening. Why didn't he mention me? But there's a few more in there now. And the announcement from Liz Kendall a few weeks back was they're going to extend it beyond health tech into multiple other areas. So the UK can truly be the best place in the world to come and build novel technologies, make it safe, and then take it to the rest of the world. Yay, Britain.
So much good news, Keith. So much good news.
Of course. I told you it was a good news story.
Yeah.
Definitely. There's things to work on, no doubt. But
Indeed.
But this is genuinely being done to try and drive us in the right direction.
Well, if people want to read more, they can go to healthtechpigeon.com. You can click on, well, it's one of the news stories this week. It's the study for this week. So you can go to healthtechpigeon.com, get that. You can subscribe to it there. And thank you, Keith, for joining me. I'm sure you'll be here again in a couple of weeks' time and we'll be chatting more. But it's amazing work, honestly, genuinely, like incredible work. I think it's one of those it's one of those pieces of work that could end up being quite a threshold moment for starting a load of work streams and mobilizing people to actually go and solve this problem. And so yeah, congratulations to you. It's really valuable stuff.
Thank you, and just look, like, I did my part, but honestly, Yusuf,
Yeah,
Elliot, Sam, God, the legends on this one too. Um, Look, as long as it moves things in the right direction, I want everyone to have fancy AI as much as like, probably more than you
probably
want it if
more.
you're
Yeah, I was going to
listening.
say
Yeah, definitely more. But no one's gonna play that game unless we can make it safe. That's it.
100%. And this is what gives everyone that confidence to adopt it.
Yeah,
So appreciate it, bro.
exactly.